Women are now in the workplace more, so their stress is higher. They also have started to smoke more. That started in the 1950s to 60s. There was a big campaign that encouraged women to start smoking, and that was one of the major turning points in women developing heart disease. And the fact that women do live longer than men, they now live past the menopausal years, and that's when the risk of heart disease increases.
So the fact that women have started smoking is the number one factor in terms of the increase of heart disease in women.
It's very important. It's probably not the number one. It's probably a combination of all those factors.
And some other reasons are what our body of knowledge has changed about the presentation of symptoms in women as compared to men. For the longest time, research and what we know about heart disease was done based on research on men. And so, you know, for the longest time we thought whatever applies to man also applies to women. And in the last 20 years, especially in the last 10 years or so, we've discovered that that is not necessarily true. The same symptoms in men may not be the same symptoms in women when they come with heart attack. So we have this whole cohort of symptoms we call the typical symptoms of heart attack and atypical symptoms of heart attack. And that is part of the reason why the disparity in, you know, what is conceived to be a heart attack in a man may not be the same as women, and so they may present, that one of the reasons why they present late to the emergency department.
So you're saying that a woman might actually be having cardiac problems, you know, manifestation, but it is not perceived to be cardiac problems.
Correct. They may not be having chest pain, for example. And that may not be the predominant symptom in a woman, especially in, for example, a diabetic woman. They may just be having trouble breathing and never have chest pain. And also how they define chest pain. You know, people perceived it differently.
Okay, no, I wanted to go back to what you just said. You said in a diabetic woman, what the manifestation of heart disease might be different. So you're saying that in a woman who is not diabetic, let's say we have two women who are 50 years old. One is diabetic and one isn't. They will present, or they might present, with the same cardiac problems but manifest differently?
Correct. Diabetics, whether it's man or woman, they may not have chest pain at all for heart attack. And diabetes itself is now considered a correlate of heart disease. So if you have diabetes, you should take it as seriously as if you have a heart attack.
Oh, so diabetes is now considered a correlate.
Actually, an equivalent. They're considered in the guidelines, in the cardiology guidelines, diabetes is considered a coronary artery disease equivalent. So we assume any diabetic that comes to the office does have underlying coronary disease of one sort or another.
Do you think I mean, I've been doing education programs, and you know, I'm a health educator. I know that diabetes is a problem, but I don't remember ever being told that it is an equivalent.
That's a fairly new concept over the past decade or so. That's slowly come into, I guess people have realized that it is really equivalent. And as we can help diabetics and keep them alive longer, we've noticed that vascular disease is more prominent. A problem.
Now, is that because of the problems that happen? What happens to the diabetic vessel, or the person who is diabetic, the vessels? Why is it that it affects the heart health? And
well, I think different things happen in different blood vessels in the body, but I think one of the predominant themes is that there is some sort of inflammatory process which diabetics, for reasons that may not be so well worked out, but some kind of inflammatory process within the blood vessels which diabetics are subject to. In addition to that, sometimes they end up getting microvascular disease. So not necessarily your the large blood vessels, but a lot of the little end capillaries and end blood vessels that are also critical to supply blood to the feet or to the toes or to the heart, and those little vessels get involved. But I think a large part of it is an inflammatory process.
But you talk about the microvessels because so many diabetics lose limbs, lose fingers and toes and some loss. I know someone in my family who a nail stuck in her foot, and you know, she washed it and things, but it wasn't like treated with disinfectants, and she ended up losing the foot first and losing the leg all the way up to the knee. Now, you're saying that these microvessels in diabetics are affected, and then how does that manifest, you know, cardiacally, you know? How does that manifest?
Congestive heart failure is the most common manifestation.
Congestive heart failure.
Yes, because what happens is the heart is not getting the adequate blood supply, either can be from the macrovessels, meaning the big coronary arteries, or from the microvessels. And what happens is the heart muscle slowly dies and doesn't function normally, and people end up with congestive heart failure.
So I would like you, Dr. Farid, to really, that red light is to the people sitting at home. I would like you to really a little more forcefully explain to people who are diabetic about how they need to pay attention to those issues, please.
So when people are diabetic, there are a few very simple things that people should pay attention to. Probably the first and foremost is their blood sugars. That needs to be regularly tested, and there's something called a hemoglobin A1C, which is a 3-month average of the blood sugars. That's supposed to be followed extremely
So that's hemoglobin A1C.
Yep.
And that's the red blood cells we're talking
Yep,
about.
it's the amount of glucose that's bound to a red blood cell, and because red blood cells are turned over in the blood, it gives us the 3-month average of what the blood glucose is.
So when a diabetic person goes to the doctor, should he or she ask the doctor what the number
Absolutely.
is?
They should ask them what their hemoglobin A1C is. And in general, a diabetic, to be non-diabetic, it should be less than 5.7. If you're
Less than 5.7 if you're not diabetic.
If you're not diabetic.
Yes.
And if a diabetic can get it to that level, that's very, very good.
So 5.7
yeah.
is the magic number we're looking for.
Is a magic number, yes. If you want to determine if you're diabetic, if it's over 6.4, then that means that you are diabetic. And in general, if you're managing diabetes, if you get someone down to 6.4 or less, you're happy with that number. And that's done with manipulation of diet, exercise, and also checking your blood sugars yourself at home on a regular basis.
And now we have those little machines you can,
That's right.
which is really
Glucometers.
easy.
That's correct.
Which is easy.
The other thing that diabetics need to watch really carefully are their lipid panels, their cholesterol. So triglycerides tend to be quite high in diabetics. Again, when you go to the doctor, you want to ask them what your triglyceride level is, and it should be less than 150.
150. So the triglycerides should be less than 150. And that's for diabetics.
That's for everybody.
everybody.
Men
Okay.
and women, diabetic or not diabetic.
Okay, so your triglycerides should be 150, less than 150.
That's right.
Okay.
Your HDL, which is your good cholesterol, that's the one that protects your heart, that you like to be high. And for women, greater than 50 is the number. For men, greater than 40.
Oh, that's interesting.
The reason why is women maintain a higher HDL because of their estrogen levels. So we have to achieve a little higher on our HDLs. for
Now,
the
is
protection.
this true for women then of all ages or
Of
on the women
all-
of childbearing age?
Women of all ages, you want the HDL to be greater than 50.
I see. But women who, after you pass menopause, you might not have as much estrogen.
That's right. And so the HDL starts to drop at menopause.
I see. Do you see a marked difference if someone who is, say, 10 years into being a diabetic, is there a marked difference in how the vessels look and how they function?
Well, by the time patients come to the point where they need vascular
surgery, yeah.
surgical procedures or any kind of cardiovascular procedures, the appearance of the blood vessels really is quite similar.
I see.
So, you know, if they came to it because they're uncontrolled hypertensive, for example, or they're
And that means high blood
uncontrolled-
pressure for
which
my-
is high blood pressure,
Yes.
or an uncontrolled diabetic, the blood vessels don't really look that much different.
I see.
But the pattern of disease is different. So, for example, diabetics will tend to have the distribution of their disease will tend to be more in the calf vessels, for example, whereas patients who have high blood pressure hypertension will tend to have disease that may be more in the vessels that are larger and higher up. So the distribution is different, but the actual appearance of the vessels is quite similar.